Hello, everybody. I'm Elisa Visconti, and I have the pleasure to moderate this panel. First of all, I would like to ask my friends here to introduce themselves, and then we can just start.
Hello. Hello. Can you hear me? Good morning, everyone. My name is Sitra Nuredin. I am a medical doctor from Addis Ababa, Ethiopia, and I currently work as a program officer at an organization called Women in Global Health, where we advocate for gender transformative leadership within health.
I'm Sarah Graham. I'm a freelance health journalist based in the UK and author of Rebel Bodies, which my publisher insists I mention. I should say my work is not in a humanitarian context, but I write about gender biases, health inequalities within the UK healthcare system and the NHS, but much of which has kind of global and humanitarian relevance.
Yeah, good morning. I'm Sabrina Schmitt. I'm a lecturer at Frankfurt University of Applied Sciences, and my study area is gender and care in the welfare state. However, I'm also a social worker, and I used to work for Doctors of the World Germany, and I used to work in the domestic mission there, so I have some insight into humanitarian work, but mostly now I'm scientifically working here.
Thank you, everyone. So before we start this session, I would like to ask a question to you. Online or offline audience. So who could tell us what are the main symptoms of an heart attack? Oh, come on. I want to believe that we all know how it looks like, right? Okay, please. The lady. Okay, what else?
For women, it's chest pain.
Well, it's pain, chest pain, and it's difficulty of breathing sometimes, and pain goes to the arms, and sometimes we have some rhythm disturbances, so that bumps a little bit behind falls, and so on.
Okay, so we all agree somehow it looks like a strong pain on your chest, something funny happening on your left arm, correct? Okay, and this is right, is correct, especially when it comes to men. The fact is that women can also have very different symptoms that could go from nausea, stomachache, pain in your back, pain on your neck, symptoms that would not recognize as signals for a heart attack. And what does it imply? That nowadays, since few decades, the number of men suffering from cardiovascular disease and having a heart attack and dying has dramatically reduced. Because we all know, it doesn't look like everybody knows, but at least some people here know how an heart attack looks like. So you call you grab the phone, you call an ambulance, and that life is saved. If you are not aware of the symptoms that a woman can have, you don't recognize them. And you don't do that thing, you don't pick up the phone, you don't call the ambulance, and that patient would lose her life. And this is what that are telling us, that yes, female patients are dying less and less from heart attack than before, but the curve is decreasing much slower when it comes to female patients than when it comes to men, where the curve was at kind of a rapid, fall down. This is what we're going to talk about today, how sex and gender does have an impact on our health, and how sex and gender has been completely neglected in Western medicine. We've been thinking, don't ask me why and how, that female body and the male body are the same. Now, I have 4 little nephews, aged from 6 to 14. I'm pretty sure they understand clearly that a male body is quite different from a female body. But for some magic reasons, our medicine has been treating the body of the two sexes as one. The way medicine has been studied, about the way drugs have been tested, the way knowledge has been transmitted, played on this idea, funny from my point of view, that the two bodies are the same. The side effects of drugs are the same. Then even, the type of disease are exactly the same. Funny, no? So why are we talking about this at a Humanitarian Congress? Well, yesterday there was a very interesting session about perpetrating inequalities. And I think this is one of the main inequalities if you think that it does concern over 50% of the world population. And also because some of us, they work for like medical organizations. So how can we be humanitarian? How can we, focus on gender mainstreaming or, all the nice and beautiful step awards for what we did when it comes to gender equality in humanitarian aid if we don't consider that gender and sex in medicine have a huge impact on our work. We are talking about the quality of our work here, and we are talking about not perpetrating injustice even more during a crisis. So having said that, I think I will have my first question for Sitra, being a medical doctor. And I would like to ask you, what did you learn about all this at uni? About how gender and sex do play a role when it comes to health.
Thank you so much, Elisa. I think this is a very important and a very real and yet neglected discussion that we have within healthcare. Oftentimes during in my medical education, the focus was on saving lives. The focus isn't on what gender that person is. It's just mainly focusing on the symptom, how do we treat it, and how do we make sure that people continue to live their best lives going forward. So what we fail to realize that the healthcare field and the provision, as well as the policies, and even how we, as Elisa said, how we make medications, how we see symptoms is very gendered, biased. And we need to understand that there are social cultural structures that influence these policies and how we practice medicine. What I believe is very important to mention as well is that when we talk about medical education, we need to see it in terms of not only the education aspect, but also how we practice it, because medical education is very related to how we practice medicine, but also how we research, not only in drugs, but also how the process of getting those drugs, how we, as the question earlier, for instance, about signs and symptoms. So what we need to understand is that when we're researching about these signs and symptoms, often we go to the default male. There have been studies that have shown that in most drug trials, the majority of participants end up being men. So when we come to how the side effects, how the outcomes of these medications is often the trial is done on men, so we don't notice these side effects. So for instance, in medical school, and even be it in Ethiopia, and in similar setups across the world, we talk about signs and symptoms. We don't talk about signs and symptoms of men, signs and symptoms of women. And this can cause differentiation in health outcomes, as we illustrated in terms of a heart attack. So when we're talking about gendering within healthcare, we need to understand that it's not only on treatment and diagnosis, but also in the process of acquiring education. It can be in terms of who is our healthcare provider. So the organization that I work at, Women in Global Health, we've done this research and we identified that 70% of the health workforce is women. And as Elisa said, 51% of the population of the world is women. So understanding these gender differences not only will allow us to understand how we treat women, be it healthcare providers, but also patients as well.
Thank you very, very much. And then, rise a question that I will ask you, Sarah, which is very much related to your research. And what is the impact on that, on all that on female patients?
Yeah, absolutely. I mean, essentially, the impact is that female patients are less well understood by their doctors. The bodies and the conditions that disproportionately affect female patients. we just know less about. There is less research, there is less awareness. And so what I see a lot in my work is women who are going to the doctors, and I'm talking here often about very privileged, white, middle-class British women. So you can imagine how much worse this is for those more marginalised, who are going to their doctors and saying, these are my symptoms, and a combination of that lack of research, the lack of medical knowledge, and the sexism, the gender bias that exists within our society means that often I'm hearing about women being told, well, are you sure you're not just anxious? Is this not just anxiety? I can't explain your symptoms. There is no, your test results are coming back normal. Is this all in your head? And that for me is a real kind of, that was what sort of got me interested in this area. In the first place, really, was a frustration that I was hearing from these very articulate women who were able to advocate for themselves, who were saying, I'm just not getting anywhere, and I feel like there's something wrong with me. When you look then at sort of the intersectional issues that come into this, black women, trans women, disabled women, that just becomes more and more difficult. And so you have these, in the case of heart attacks, as you were talking about, women are 3 times more likely to die than men. And that is partly down to biological differences, but actually there was some research, really interesting research by the British Heart Foundation, which found that even the very small biological differences that there are not enough to account for the difference in care. It is bias. It is the fact that doctors do not recognise that women might be having a heart attack in the first place. It's seen as something that affects middle-aged men. And so we see these kind of disparities all the way through healthcare.
And how is it to be a female doctor? How did you, what was your experience at university now that you're practicing?
So in Ethiopia, the way that the educational system works is that when you straight out of graduating from high school, you apply for a national exam, and then you're placed into different medical schools. So in my case, for instance, I'm the first medical healthcare professional within my family. So that being also a woman that has its own struggles, but oftentimes in Ethiopia it's considered that the healthcare field, particularly medicine, is for men. And I'm sure that these kind of nuances are across in different countries. For instance, in my work, I'd meet with people from Asia, from Latin America, etc., and we see these nuances where we think that, for instance, surgeons, the default image in our minds is men rather than women surgeons. Or oftentimes when we think of pediatricians, we think of women instead of men. And so what I've noticed in my studies, it comes from not only before even entering into medical school, people will often be like, are you sure you can do this? What about you having kids? What about getting married? These kind of instances are mentioned. And then even after you join medical school, for instance, in a class of about 120, only 20 of us were women. So even when we came to practicing medical, for instance, we have clinical years, and in clinical years, when we're interacting with our patients, oftentimes our patients will ask us, can you please bring the doctor? Or they'll look at our fellow peers and be like, they'll call us nurses, or they'll call us sisters, please call me the doctor, I don't want to speak with you. And oftentimes there might be times where, particularly I've noticed it in elderly men, they'll say, I do not want treatment from you, please call the doctor. And oftentimes when you tell them, they're like, no, I need another doctor. And there's these kind of discrimination and sorts that happen not only within Ethiopia, I believe, but across different health facilities. But we also, I feel that it's the best way to look at it is through the medical education aspects, but also through treatment and also interaction with colleagues. So how men colleagues will stand up for women at times. And what I really want to mention is when we're mentioning about women and gender equity, this isn't an issue of just inequities. We need to understand that this is deeply rooted in how we think about men and women, not only in healthcare. So one thing that I've noticed, for instance, and I've actually noticed this after I graduated, is that, for instance, we had surgical gloves, and albeit few at our institution, and they were always size 7. And I never realized the size of the surgical gloves, but it was always bigger for women. So oftentimes when we're supporting in cesarean sections, it would be very difficult to hold the instruments. And I never really thought of it as an issue of size. And I've always wondered, is there a lesser size? But I always thought it was because of the facilities and how we're under-resourced. I did most of my training at the second largest tertiary care institute, so it was very under-resourced. People would pay very few because they come from very remote villages, and it was effectively, I would say, just free. So what we realized is oftentimes we would drop instruments, it was very difficult to hold, and I didn't realize it until one day. One of our gynecology seniors, who was an attending, who was a female, she came and she was going to do this very important procedure for a woman who's bleeding after giving birth. And she was going to, if she didn't stop the bleeding, she would need to have a hysterectomy, and that means she wouldn't be able to give birth anymore. And I remember her screaming, and she said, "Get me a size 6 glove." And everyone kept running around trying to find it. And then I realized it as we were doing our work on the COVID pandemic. We realized that personal protective equipment, even during the pandemic, was not fit for women. But as I mentioned earlier, 70% of the healthcare workforce, and oftentimes 90% of the frontline healthcare workforce, is women. So when we're not thinking about, when it comes to gloves, when it comes to personal protective equipment, when it comes to anything that is related to provision of healthcare and also to receiving healthcare, we need to make sure we have that gendered lens, so we understand that we're not just thinking of men, but also women when it comes to these issues.
Okay, since women are invisible as patients, women are invisible as doctors or health staff, Sabrina, does this have anything to do with the way knowledge is produced and transmitted?
Yeah, not surprisingly, it does. I just want to make one small remark, because that also links into knowledge production. We are talking about gender in health, and gender also includes queer bodies. And female bodies are not homogeneous. It's not a homogeneous category. I mean, that's obvious, but I just want to point it out that when we talk about women or female people in the health system, we need to look at it from an intersectional point of view, that intersectionality is a concept implemented by Black women, thought of from Black women, and I think we need to, I mean, it's complicated, but I just want to make sure that there are different layers to the term female and women. So how does and this also affects, of course, knowledge production, because the kind of knowledge we are producing, and I'm talking about a deeply racist, sexist, ableist institution like a university or academia. The way we produce knowledge is that if we produce knowledge on gender, we produce knowledge on a gender binary. So we produce knowledge on women, quite often not really questioning what women we are thinking of and what women we are doing research on. We rarely produce in academia knowledge on queer health. So how does the health system affect bodies that are not recognized in the same way as the gender binary bodies are? So we don't produce any knowledge on how do we deal with gender affirming healthcare, for example? How do we what is the difference between women of color and white women? How does it affect able-bodied women differently from disabled-bodied? So we produce knowledge, but only in a very specific way, only in a very binary, able-bodied white way. We ignore the work of predominantly black, but also indigenous women that produced knowledge before colonialization on gender. And so we have a very colonial idea of health and gender. And this is what we implement in the research, at least the research I can speak of, the social science research. So we do not account for the colonial and patriarchal and heteronormative idea of gender and medicine. So this is the kind of knowledge there is some knowledge, of course, but like the knowledge that is usually cited is on women and women's health rather than gender health, which is a difference. And then there's another question of who produces knowledge. And I mean, this is all obviously not surprising as well, but it's usually produced by upper class, white people. More and more women are are professors, are lecturers, are in considerably high positions within academia. I mean, it's still 30%. It's not a lot, you know, but still there is an increase, at least for the German academia. I can say that there's an increase in female professors. However, most of them are white, most of them are upper class, most of them are able-bodied. And so there is an increase, but on a very low level, and I don't think we need to, and also we cannot assume that these people produce knowledge on gender. Just because there are women in academia, that doesn't necessarily mean that there's gender in the, you know, and it's not the responsibility of these people to research on gender. It's the responsibility of academia to find out, you know, to understand phenomena, to get an idea, to generate knowledge. So the people who generate knowledge are usually not female. If they are female, they are privileged, and the kind of knowledge that is produced is very within the line of colonial, patriarchal ideas of health and gender. And this is a major problem and is also, you know, quite often recognizable in the syllabus. So in the curriculum, you can see if gender is addressed, it's usually in terms of physiognomy. I'm not sure if I said correctly. So what they look at different chromosomes, yeah, but they do not look into what effects do drugs have on different bodies. So what treatment do we offer? What barriers are there? So it's a very, again, westernized idea of the body, health. We look at specific chromosomes, and this is how, you know, we try to determine what intervention we need. So this is the kind of gender perspective that is, there are a few studies on that are introduced in curricula. However, there's not as much, it's 8%, one study says, on gender in the sense of how do we deal with gender related barriers, how do we have drugs tested in a way that is gender sensible. So there is a lot of work to do.
Thank you, Sabrina. It seems that the female, and bodies, I would say, are kept invisible from academia, from research, from production knowledge, and from practice. But still, those same bodies are very much politicized. It seems now, it has always been like that. The politics, religion, establishment plays its game on female bodies. And it's all about reproduction, correct? So how do you feel about that? Why is that? Why these bodies are on the one side invisible, on the other side they are super politicized. You have like referendum about female bodies, and when they're politicized, it's all about the reproductive system. We have 2 minutes for that question.
Okay, well, I find it awful, and I think we need resistance. However, I think when we have a politicization of women's bodies, but they are still objectified. So women are rarely, the female body, the female red body is rarely a subject, a political subject in its own. It's an object that is to bargain around political issues. So we have the discussion on Germany with the reproductive system. There, in Germany, abortion is criminalized. It has been for ages. It is allowed or not criminalized under certain circumstances. There's been a strong feminist movement calling for the abolition of this paragraph. And it never happened, even though there has been some slight changes in the ways you can, obtain information on abortion. But we are not and I'm talking here as a cis white woman, we are not granted rights. We have been given some narrative in terms of, now you can have some information. But there's a discourse on feminism, but that doesn't lead to more rights for women in the healthcare sector and, anywhere. And this is not a German problem, obviously, when we look at the US, So what I observe is that we have a rhetoric that says, we need to talk about gender, we have a panel on gender medicine, which is, important. But that doesn't lead to a proper representation of female people or in a diverse way on a political level, and it doesn't grant us basic human rights. And I think that's something, that is, it's obscured because we feel like everyone says, we're talking about feminism so much and equality, it's always an issue, but it's rarely ever really an issue, if you know what I mean. So it doesn't lead to policy change, at least not for the German case and from what I know from Europe. It's rather getting more difficult to have access to healthcare. So I would say they're politicized in a way of objectification. They are, if needed, used for racist narratives, especially in Germany, but they're rarely granted a subject status in which they have agency and political power over the narrative that is created. And so that's
Thank
a short
you,
answer.
Sabrina. Sarah, do you have a comment on that?
I think you're absolutely right. There is a real issue around, as you say, lack of agency, lack of autonomy, and women's bodies, and equally, as you mentioned earlier, queer bodies, trans, non-binary bodies, being thought of solely in terms of the patriarchal system that they're within. And so much of that is around control. It's not about autonomy. It's not about individuals. We see women being thought of in terms of men, in terms of their, male partners, if they have one, in terms of their children. One of my favorite quotes from my book was, I interviewed a gynecologist, and she said very, very candidly, as gynecologists, we are trained to think about the vagina in terms of, can you get a penis in and can you get a baby out? And I think that really tells you everything you need to know about the politicization of women's bodies. We are vessels, for male pleasure, for reproduction, and particularly if you're someone who doesn't want to get a penis in or a baby out, where do you fit within that?
Well, imagine how all this has an impact when you have to deal with people from different, we have different bodies, especially when you work in the humanitarian sector. You will not find me as one of your patients during a war in, whatever country outside Europe. So the impact on the fact that we don't study, we don't know how other female bodies or queer bodies function. It has a dramatic effect, even in terms of life-saving, if we want to go back to the humanitarian discourse. We can barely see our own bodies within our own society. Imagine how can we see different bodies of different colors, different shapes, different societies. So that is what is concerning us. And to wrap up, I think we have a few more minutes. There is a question we asked ourselves, and we struggled to find the answer. We had few answers, but maybe it would be interesting to open a debate and to ask to all of us what the answers could be. And the question is how to reduce barriers when it comes to knowledge, when it comes to political politicization, that's really strange for me, of female bodies, of colonialism behind the way we read female bodies. What can be done? Oh, we have a question from the crowd. Cool.
This is very personal to me, but I think because it's also Breast Cancer Month, I should just share it. I live in Germany. I'm Nigerian. I was misdiagnosed for 3 years. It was not until I watched a YouTube video that I recognized the symptoms I was having. For 3 years, when I went to my doctors in Germany, I was told it was a heart attack. It was tumors pressing on my chest. Because it was 3 years, I asked for a radical mastectomy, which is a flat chest. I was sent for a psychiatric evaluation. They couldn't believe why a woman of 34 years at the time don't you want breasts? My therapist asked me, and I said, don't you understand? You guys misdiagnosed me. I'm tired, I want it out. And the funniest thing was, after having this surgery, they didn't know what to do with my now flat body. I didn't know how to walk. My gait actually changed. They didn't prepare me for it. Apparently, no matter how small your breasts are, they help you balance. But everything I learned about how to dress a flat chest was from the queer community. And it started from when I was watching RuPaul's Drag Race. How to dress up, how to actually walk and balance after surgery. It was from people who had had top surgery. And I'm sharing this to say, if I had a doctor who was also watching YouTube and could see the symptoms I saw, that then made me say, I'm not going to wait, you must refer me. If I had a doctor who understood that top surgery is something that should not be frowned at if you are not in that type of surgery. It can actually help you as a gynecologist, as a plastic surgeon for women. I wish more doctors would not be so elitist. This is how I work, this is not how I work. Because I'm a living example of how intersectionality can actually help. So what I suggest doctors should do is open up themselves. Not everything about health is in a textbook. You can learn from YouTubers sharing personal stories, and not everything is in one science or one type of body. You can learn from even the LGBTIQ community. Thank you.
So, more RuPaul's for everyone. I'm a big fan, by the way. Any other thoughts on that? Like, I think we have a few more minutes left. Ah, fantastic. So let's keep going. So what can be done to break those barriers, to see other bodies, to enlarge the way we learn, the source of information? There's a lady over there.
I have a question that we could develop together regarding data collection. Yeah, so gendering comes along with several intersectionalities, as we just heard. How could we improve, as humanitarians, the data collection? What kind of information should we collect so we could offer a better treatment? And how to be careful with some barriers that we have in place at some times, that people believe that it can be discrimination to ask about race instead of asking about race and providing a proper treatment.
Who wants to answer that one?
I feel like I have to, in a way, but I can't. Since I don't, I work qualitatively, so I can't speak of quantitative data. However, what I would like to emphasize, and thank you for sharing that, what you just said, is that we need that we go beyond data collection and look into concepts of health. Yeah, this is like another whole discussion. but to understand that health, the idea of health, the idea of research is in itself deeply gendered and colonized. And I'm not saying we can get beyond that, because we can't, but I think we need to understand how situated we are in these contexts and how they inform the questions, the research questions we ask. So the questions I ask are strongly situated in my biography, my cisgendered body. I'm not a neutral researcher. I'm not objective. I mean, of course, there are ways of validation, and scientific methods. But to understand that we are asking questions from a standpoint, and I'm not advocating here for feminist standpoint theory, because that's a whole nother level, but I think to situate ourselves and think about the questions we ask, and obviously democratize knowledge production. It's not on us to research. Loads of people do great research. It's called, citizen science is a new thing, but everyone does research in a way, and or collects data. And I think to take this into account and situate ourselves, and don't think that we are the only ones that collect data. There is data. It's just we need to listen to the people that have it, if you know what I mean.
Yeah, absolutely. I think, coming back to your point, a lot of the work that I've done with patients, and particularly patients who have felt ignored, who have been misdiagnosed or dismissed, is, I have seen a huge sort of network emerging, I suppose, of patient advocates, patients supporting other patients, of women and queer people who, because their doctors do not understand their bodies, have sought out information from each other. And there are huge challenges there. We know there are huge risks with all of the information that exists online. Is what you're seeing evidence-based? Is it safe? There are huge challenges to deal with there, but I think what we need is a much more collaborative conversation between healthcare professionals, between researchers, between patients. There's a real sort of divide between, in terms of the knowledge that we see as important, the knowledge that we prioritize. I think for a long time there has been this idea that medical knowledge is a fixed, infallible thing, and that the doctor knows best, and that anecdotal evidence is not really evidence, old wives' tales and traditional remedies and things. But actually, I think what we need is a more collaborative approach that says, okay, we have a lot of gaps in our knowledge about women, in our knowledge about queer bodies. But what can people tell us from their own experiences, and how much are we listening to that? And really kind of bringing that into our medical practice and understanding, and informing the research that we do going forwards as well, I think.
If I may just add to that, as a person from the Global South, and particularly Ethiopia, I understand that in a lot of humanitarian contexts occur in countries like my own, again, Ethiopia. And I understand, and I think it's very important to understand who we're collecting data from, and it comes a lot back to contextualization, understanding that a lot of people on the ground, oftentimes research is done majority from the global north to the global south, when we see it that way. And sometimes we need to understand contextualization is very important. So studying about health issues and health systems in the global north is very different about health issues in the global south. So things that are affecting us in Ethiopia is very different from, let's say, in London or in the UK and in different parts of the world. So when we're collecting data and we're collecting, why do we need that data? What are we going to ultimately be using that for? So for instance, even when we talk about sometimes gender, but intersectionality is also very, very important. So oftentimes when we talk about gender equality, it's kind of like that tick box of, the SDGs or like conferences or things that are mentioned. But we need to think about that even women in and of themselves are diverse. So when we're talking about it, when we started the session, we talked about heart attack, and then we divided it men and women. But we need to understand that not only heart attacks, but other diverse issues are very different. And in order for us to provide the quality of care that we have, in my case, as a healthcare professional, I have an oath to protect, is that we need to make sure that the person that we're treating is being treated in the way that is to their specific context. So that I feel is very important, particularly as humanitarian workers. That's something we also need to keep in mind and always at the back of our heads.
Thank you very much. I think there are two more hands over there.
So I have a question regarding the topic making new knowledge, like that there is a lot of knowledge about the male body and about the male physician, and also so many drugs are tested on male. So is there a change in this already that we see, okay, how can we research the female body in a different way? Because it's, with our period, it's just different to what, or how male bodies are functioning. So I guess the data is not so nice and clear, like if we do researches on male bodies. So this is one of my questions. I think I keep it with that for now.
I think from my perspective, we are seeing some progress in terms of research. I think, when you look at the sort of historical context, and again, I'm talking very much in a kind of Western, global North context, but for many years, women were just completely excluded from clinical trials. And what we have now is more of an effort, more of an expectation that gender and sex aggregated data is included in research. We still have a really long way to go, and we're seeing, as you mentioned, more and more female researchers coming into the area, and I think there is a shift in terms of what is seen as important and valuable to research. But there was a study published in America in 2021 which looked at funding for different conditions, and it categorized those conditions into the ones that disproportionately affect men, the ones that are gender neutral, and the ones that disproportionately affect women. So things like endometriosis, but it was also included migraine, chronic fatigue syndrome, ME/CFS. And what they found was that relative to the burden of those diseases, all of the conditions that disproportionately affect women are underfunded, and all of the conditions that disproportionately affect men are overfunded. So we still have a really long way to go, and I think, as many of you will be aware of, with your humanitarian work, funding is always a huge issue, and who makes decisions about what is important to fund and to pursue.
I think there was another question over there.
Sorry. Thank you. So my question is more for Sabrina. I want to ask about this knowledge production and what you talked about being very narrow in terms of the way we produce knowledge. So mostly here in the West, universities are structured in a way and the research is being done in a particular way, which very much discredit the way that indigenous people and other population from South might do the research or collect the data. I want to get a sense of what do you think is the way to change that? You, if I'm not mistaken, you said it's not possible even for you that are in academia. There's not a lot you can do, and there's a lot of expectation that if you're a woman, then it's your responsibility to research on the fields that might affect women. So I want to get what is your suggestion, and is there a hope that we can change that? Thank you.
Thank you. Difficult. I will share something very personal as well. I'm quite surprised by the way the system incorporates, you. So I started off trying to say, yeah, we need to, all knowledge is valuable, the colonialization of knowledge, which methods are we using? So, I started off really wanting to change. So, and then I realized as soon as you're within this also capitalist system, that is called academia, especially in the academia I know. I realized that I was very much sucked into this whole narrative, and found myself thinking, oh, do I really need to do a seminar on gender as a colonial category? Oh, it's going to be so difficult, and the students, so much discussion. And this is a very personal thing that I'm struggling with. For example, I'm coming from a very working class background, and I can see how I'm becoming more and more bourgeois and upper class in my habitus. So this is something that I don't know for me personally. However, what I do know is that I think especially me as a white scholar, we need to work on the idea of what science is, and I think we need to do that continuously. And we also need, I'm talking about white scientists, for example, need to incorporate the knowledge that is generated, has been generated for years and years by women of color or people of color without capitalizing on them. And I find that quite difficult because, it's already like a performative thing to say, yeah, I'm doing like a post-colonial study here, I'm a white, I'm very aware, critical whiteness, this, that. So, okay, it's difficult, I don't know the solution, but what I know is that there is a lot of knowledge within communities. And I think if we empower communities to have a voice within all of this, and we stop doing scientific congresses that basically are just another stage for us to say how great we are. I think we need to really open what science is, but this is not a very concrete thing to say. So I don't know the answer, but I thank you for the question. I want to encourage everyone. Natasha Kelly, black scientist, she said to read one black author this month, and I will encourage, for example, everyone to do that, or someone that is not on your syllabus, or is not been cited 1,000 of times, not because their thoughts are greater, but because it's just how the system works. So this is
Any other comments on that question? I had the feeling, Sitra, you were on the edge of saying something, but maybe it was just between yourself.
I was just really, you articulated very perfectly about local knowledge and making sure that the people we are claiming to serve are included within our service, and making sure that I just yes, I was definitely at the edge of my seat, just nodding.
Yeah, absolutely. I think also I was very struck by, this idea of, how do we relate this to humanitarian work? And one of the things, one of the healthcare professionals that I interviewed for the book, who does a lot of work with Black and ethnic minority communities and outreach was, she said often we talk about hard-to-reach communities. But she said, for me, there are no hard-to-reach communities. There are only hard-to-reach services. So for her, a real priority was how can we make this service accessible? And whether we're talking about the UK or Ethiopia or wherever it is, how much are we listening to that local knowledge? How much are we taking it on board? Whether you're a healthcare professional or a humanitarian or whatever role you're in, is that idea that that knowledge is important, and that we often thinking about sort of cultural sensitivities as well. One of the things that I've seen a lot in my own work in the UK is a kind of a stigma, which we are seeing slowly, I think, in the West start to start to break down a little bit around talking about women's health issues, particularly around period problems, menopause, etc. But I think, so thinking then about communities where actually those conversations still are not happening, how can we be the ones in a non-intrusive way to start opening up these conversations and asking the questions that are perhaps difficult and looking at the issues, thinking about, how do we prioritize these issues that perhaps people have been keeping to themselves for generations?
Thank you. I have to say I have a problem with the word like local communities knowledge, because I always wonder what is local and what is non-local. I guess this is also something we need to, at least I try to reflect about, is that health, science, knowledge and bodies are not just white and men and old. So what I have an issue to consider like medicine in Ethiopia is local, and local compared to where. And so we need to, to listen to the local. I think the idea I have is that knowledge should really and truly be horizontal. And then you exchange that, and not that you, as it is, like put yourself, somewhere up here. And then, I can listen to you, you're local, but I think you know a bit. This is something as a humanitarian worker, I've been a humanitarian worker myself for a long time, I had to struggle with on a daily basis, the idea that there are also other people, also other community that you might want to listen to. And I think we are still very much trapped into that concept when it comes to humanitarian. We have 2 or 5 more minutes. I don't understand the signals, and and I'm not wearing my glasses, so I get 7. So in these 7 minutes, if there are any other comments or answer to our questions, I think there is one.
Not really, but we actually got an online question I want to read out. As a humanitarian person, we need to respect the localization, like local wisdom, localized treatment or other genders that accept in the society, in the location where we work. How to improve our services to people affected, patients in terms of treatment in relation with localization.
This brings me to, the question reminds me of a discussion that we were having last year. The organization that I work for, it's called Women in Global Health, and we are a global network of women in 51 with 51 chapters in 47 countries. That is of women working in health globally that have come together to advocate for gender equality within healthcare leadership and different issues on, for instance, SRHR, UHC, etc. And we were having this discussion about advocating for women, about women within our different countries. And there was a particular discussion about what we advocate for and to who we go out and advocate to. And I remember this discussion because there was a lady that represented our Somalia chapter, and there was a lady that represented our UK chapter, and there were different chapters that were represented. And they were talking about issues that they would raise to governments and what they would be discussing about and why that's a priority. And I remember this instance, a representative from Women in Global Health UK, she mentioned about LGBTQI and how the need to advocate for equal treatment in terms of healthcare and provision and access. And our colleague from Women in Global Health Somalia, she was very shocked. She said, if I were to mention this, if I were to mention about LGBTQI practices to government, to the Somali government, to the Somali Minister of Health, that would be an issue, that would be a whole different issue. That would mean we may not be able to continue with any other advocacy. Oftentimes when we think about localization, and maybe others can also speak to this, is my personal aspect is, when we're doing work in Ethiopia, we need to think about the Ethiopian cultural context. But when I say Ethiopia, for instance, I grew up mainly in Addis Ababa, which is the capital city. And I understand that if I were to go and work, For instance, in Benshangul Gums or in areas near the Sudan border or the Kenyan border, there are different cultural norms. There's different sensitivities that we need to be attuned to. So for instance, we went on a 6 weeks attachment to an area where it's a Muslim majority area. So when a Muslim woman came to receive their care, oftentimes they would be cared for by other Muslim healthcare, other female healthcare practitioners. And if, for instance, a man were to come and just try to treat, she would be taken aback. And similarly, what I experienced was that when an elderly man came for instance, a catheter change, and I was trying to support him, he was like, "Don't come near me." And understanding, for instance, the cultural sensitivities and the local realities within those contexts is very important, because it's also how our patients or how the people we're providing care to receive and perceive the care that we are giving. So it's not only just about the care we're giving, but also the perception of the perception of our patients about the care they have received. So that's what I consider. It's just kind of thinking about not like global north, global south, not only just that, but specific to the context that we're in, and realizing that patient's care or provision or receiving that care is one-on-one, and just kind of trying to understand that.
Thank you, Sitra.
May I just add one more thing? Not really add, because it's been great. I just want, from a social work perspective, it's not the same as a humanitarian worker necessarily, I know that, but we keep asking in social work, how can we reach such and such and such and such? But to understand that there are boundaries, and not boundaries, but limits, and that we might also not be equipped within a program to serve all the needs. For example, in social work, not every social worker is well equipped in terms of competence to work for a queer community. It's not like an add-on to say, let's do some queer counseling. Yeah, I'm talking for a social work context. This is specific knowledge that you need and competence, and to also understand that you can't do it all. And it's probably a good thing that you can't do it all, because there are people, like the people we want to address will have different needs, and you need to meet them with different competences, maybe. So, that might not apply to a humanitarian emergency setting, I understand that, but just in order, like the way we think about it, we need to do it all, and this vulnerable population and this, but it might not be possible to do that in every instance, and that's tragic, but that's a political problem, and not the problem of individual people to solve.
Thank you, Sabrina. I think it does apply very much to the humanitarian context. 1 minute remaining. I managed how to read it, I don't know, but yeah. It does apply to the humanitarian context, where we all want to save lives. That's, what our engine, but sometimes limits have to be taken into consideration. So if I have to wrap up, and it's impossible to wrap up this session, I will be creative. I will just have 2 keywords in my mind. One is to listen and to be humble. I think science needs that. And I think that in the case that was shared by our friend before, if a doctor or doctors would have listened, maybe things would have gone differently. And the other keywords in my head is like hubris. I don't know how to translate that in English. It's, I think that's Greek. It's like when you think you can do more, like you think you have control over the world, like you can break any limits. You're like God sort of thing. And you don't realize that other bodies exist, other bodies matter, other knowledge matters. And then, you cannot do it all. So I think that's the only thing that comes into my mind to wrap this session. That I would continue going on forever, but we can't. And thank you, everybody, for those who have been participating. And for these amazing ladies, we had real fun these days, chit-chatting to each other and trying to give a shape to this panel. Thank you.